I'm Dr. Cornelia Graves, and I am the State Medical Director for TIPQC. We are currently doing a project on cardiac conditions in pregnancy. This lecture is on cardiac arrhythmias. We know that cardiac arrhythmias are a leading cause of maternal morbidity and mortality. And we hope that during this time and through this lecture, you will feel more comfortable in taking care of this patient population. So the objectives of this lecture are to discuss the etiology of cardiac arrhythmias in pregnancy, to develop a differential diagnosis for these arrhythmias. We're going to be looking at how you can look at abnormal and abnormal EKGs in pregnancy, as EKG findings can change during the pregnancy period. We're going to discuss the management of common arrhythmias, and then really address the effects of arrhythmias on the fetus. Arrhythmias, like I said, are very common in pregnancy. Most occur in patients with a previous history. And they may be associated with underlying cardiac disease, as pregnancy may cause metabolic stress that actually unmasks the cardiac disease that is present. Most arrhythmias during pregnancy are benign and don't cause any harm to the mother or the fetus, but can be very uncomfortable. Arrhythmias are also 1 in 5 independent risk factors for an adverse pregnancy or cardiac event. In the UK, 9% of cardiac deaths were defined as sudden death syndrome, and it was felt that these were most likely due to maternal cardiac arrhythmias. So let's talk a little bit about the incidence of cardiac arrhythmias in pregnancy. They're ectopic beats and kind of non-sustained arrhythmias, often tachycardia, and these are encountered in more than 50% of pregnancies. If you send a pregnant woman for a Holter or what we call a ZO monitor or an event monitor, you will often see that the patient will have episodes of tachycardia, can occasionally have irregular heartbeats, but none of these are associated with long-term pathology. About 2 to 3 in 1,000 pregnancies will have sustained tachycardia. Often you will see what we consider sustained tachycardia in multiple gestations. This has to do with the increased cardiac demand during pregnancy. And only occasionally, about 1 in 20,000 pregnancies will have a pathologic bradycardia. But later in the lecture, we're going to talk about bradycardia and when you may see it in the pregnant patient. Now, physiologic changes in pregnancy we're going to talk a lot about, because these physiologic changes often affect the heart. First, there's increased cardiac output. Cardiac output is increased 30 to 50% over baseline. This is for a singleton pregnancy. If you happen to have twins, triplets, even quadruplets, that can increase significantly. So, for example, in twins, it's about 70%, and then for triplets, about 80%, and then for higher order multiples, you can imagine the amount of stress that's put on the cardiovascular system. There are changes in plasma volume. During pregnancy, plasma volume or blood volume increases by 50%. Most of this is due to plasma volume. So in patients, you often have what we call a physiologic anemia. Your red cell mass goes up about 20%, but your plasma volume makes up about 30% or over half of that increase in blood volume during pregnancy. These things cause changes in the atrial and ventricular myocytes, changes in depolarization and how rhythms or impulses will flow through the heart, changes in refractory time, how long it takes the heart to recover, and it can slow conduction. Again, why we can see arrhythmias in pregnancy more commonly than we would in a non-pregnant state. It is also felt that estrogen and progesterone can be pro-arrhythmic. This has been shown in animal studies, and we know in postpartum women, we will also see changes in cardiovascular irritability, which have to do with fluctuations in hormonal status. Well, we know that there are some mechanisms for arrhythmia generation, and a lot of these have to do with already congenital heart disease that the patient may have. So if the patient comes with structural heart disease, such as an ASD or VSD, or a repaired tetralogy of Fallot, or valvular disease such as mitral valve prolapse, or as I had recently, a repaired Epstein's anomaly, you might see more arrhythmias in these patients. Then there's acquired heart disease, valvular heart disease from rheumatic fever. Now, In the United States, rheumatic fever is not very common. However, in countries in which do not have the same type of health care as we do in America, especially for children, you're more likely to see rheumatic fever. And in fact, in some places like Micronesia, rheumatic fever is so indigenous that they stay on constant antibiotics in order to prevent their structural heart disease. In addition, there's endocarditis. Now, while endocarditis is acquired, the most common cause of endocarditis in our patient population, especially in Tennessee, is substance use. IV substance use in particular increases the risk that you will have vegetations on the valve, which can cause issues with valvular function and actually long-term issues with the heart. Cardiomyopathy, which can be acquired during pregnancy as well as prior to pregnancy, can increase the risk of arrhythmias. And then there are structurally normal pathways. The more we learn about sodium channels and those types of things and their effect on the heart, we know that there are nodal conduction pathways, there's WPW, and then of course there's prolonged QT syndrome, which one may not be diagnosed with until they become pregnant. Last but not least, you can have degenerative diseases of the heart and the connective tissue, such as an autoimmune disease. And then we ourselves can make the QT prolonged by giving the patient drugs or other metabolic issues that can occur. Just recently, I had a patient who was a transport, and I was really concerned about her QT because it was prolonged. And so we checked her thyroid, and lo and behold, she was hypothyroid, which is another cause of prolonged QT syndrome. Now we're going to talk a little bit about the diagnosis of arrhythmias in pregnancy. So the first thing we need to do is look at history. Is the patient, when she says that she has an issue, does she have syncope? Does she feel like she's going to pass out? Does she have pre-syncope where she feels like she's going to pass out but doesn't pass out? Chest pain, shortness of breath. We know all pregnant women have shortness of breath, but is it out of the usual? Has she had previous issues with this? What has she been doing? Has she been drinking fluids, or has she been working in a hot warehouse where she may be dehydrated? What about the medications that she takes? Anybody in her family with issues? Family history is really important when talking about heart disease. I take a lot of time asking the patient about this. What about sudden cardiac death? Was her father out running and all of a sudden he passed out and had what they considered was a heart attack? What about arrhythmias in the family? And then do they have medical problems? I just mentioned hypothyroidism, but hyperthyroidism can also cause cardiac issues, along with blood clotting disorders, which can cause little micro clots in the cardiac vessels, resulting in a heart attack. And then, of course, autoimmune disease, which we see often, lupus anticoagulant, and a phospholipid syndrome, a Sjogren's syndrome. All of these can have cardiac defects. Now, let's talk about exam. You have to do a resting EKG. Now, on your resting EKG, know that these things can happen. There's a decrease in the PR interval. There is decrease in the QRS and the QT interval. In fact, prolonged QT is diagnosed different in pregnancy than non-pregnant state. Your mean QRS will shift to the left. Why is that? Because the pregnancy rotates the heart up and out to the left. There are minor S to T wave changes, and then there's small Q waves with T inversion in leads 3 in AVF. What does that lead to our machine reading? Anterior infarct of unknown significance. That's a normal pregnancy EKG. In addition, as we talked about, those extra heartbeats are often common, so you may see them on the EKG as well. Now, you're like trying to figure out, is this arrhythmia pathologic? What else can I do? An exercise ECG or EKG is not contraindicated in pregnancy. All you need to do is make sure you don't exceed the patient's exercise tolerance. Otherwise, you can get an exercise EKG to help to see if the arrhythmia is induced or reproduced with exercise. Let's look at our echocardiogram. We want to get an echo in pregnant women so we can rule out structural heart disease. Maybe the patient does have mitral valve prolapse, but she just doesn't know. We also want to rule out cardiomyopathy. As I said, often this is diagnosed during pregnancy. You can also get a prolonged ECG where you put on a monitor called an event monitor Holt or ZO monitor, which you can do from 48 hours to 2 weeks. But Also, during this time, you need to make sure that the patient keeps a diary. Did she feel short of breath? When did she have chest pain? Does it correlate with the events that you got off of the testing that you had? Now, last but not least, if you feel that you need to do more testing, you can do pharmacologic or electrophysiology testing in some cases, especially if we feel the arrhythmia may cause problems or mortality or morbidity during the labor and delivery period or throughout the pregnancy. I'm just going to go through a few things on EKG interpretation for those of us who don't normally interpret EKGs. Now, during the EKG, you get a PR interval. The PR is really your SA node kind of coming out here. And then you have kind of a depolarization of your atrial node. That's your PR. And then your QRS, you have atrial contraction, depolarization of your AV node, repolarization of the atrial area over here. And then you get your ventricular repolarization toward the end. Keep in mind that what you're really looking for in these pregnancies is you're looking for whether or not there's ST elevation, if the rate is normal, and those are the things that you have to ask yourself when reading an EKG. Let's look at our R to R interval. Is it normal? Is it abnormal? If our R to R interval is normal, that means our ventricular rhythm is normal. Let's look at our P to P interval. Is that normal? That means our atrial rhythm is normal. So right there, if you looked at the R, that's the peak, and the P, which is the first hump, you've already ruled out whether or not the patient has an abnormal rhythm. Let's look at our QRS complex. Are they wider, narrower than normal? Do they all look the same? If they're widened, you may have enlargement due to the pacemaker that the patient has, so you need to ask. If it's narrow, again, that could be associated with a supraventricular rhythm. Again, you need to ask the patient whether or not she has a pacemaker because that's above the AV node. And then if it's complex, maybe the patient has her own, what we call copic pacemakers that are causing an issue. I talked about, are the P wave similar and is the PR interval normal? If it's normal, then your SA node or your sinus node is your primary pacemaker. If it's varied, there may be other pacemakers going on. If it's long, then you might have AV block. And if it's short, it just could be because you're young, you're a great athlete, or you have a benign syndrome called Levine-Ganon syndrome. So it does not mean that it may be pathologic, but those are the things you're looking for. And a short PR interval is less than 0.2. Is the rate normal? Is it greater than 120? Is it less than 60? Do the waves and complexes proceed in a normal sequence? Is each P followed by a QRS, followed by a T? If not, then these are all parts of a normal EKG. And does the ST segment stay on the line, or is it elevated? An elevated ST segment is associated with cardiac ischemia. Let's think about this just a little bit. So if we have a normal sinus rhythm, sinus bradycardia or sinus tachycardia, that's normal. Junctional rhythms, which means that your P R may be looking a little different, that's normal. Then you can have supraventricular tachycardia or atrial flutter. Those are the things that you need to be concerned about. Those are abnormal. Then in the ventricular rhythm standpoint, what we're looking for are PVCs, that widened ventricular complex, which may tell us that we have some type of ventricular rhythm going on, or we may have a third degree AV block. So let's look at some cases. So this is a 40-year-old, gravid 1, parent 1, 5 days postpartum, comes in with a headache. Blood pressure is 180/100. She's satting 96%. She denies any shortness of breath. And the most important things about her labs is that her BNP is 412 and her hematocrit is 32. The rest of her electrolytes are normal. When you look at her EKG, you will see that her rate is 55. What does one do? Patient has bradycardia. We see this often in patients who present in the postpartum period with postpartum preeclampsia. What is it that causes the bradycardia? Remember, I told you that pathologic bradycardia is actually really abnormal in pregnancy and very rare to be seen. So why is it this patient is bradycardic? Her BNP is elevated. Her symptoms are associated with what the body thinks is a full right atrium and that her preload is high. This leads to vagal stimulation, feedback on the parasympathetic nervous system, and a decreasing of heart rate to protect the amount of perfusion that goes to the brain. It can be associated, again, with hypertension, and while it may be associated with complete heart block, often in these women, correction of their BNP, treating their blood pressure, and taking care of the thing that's causing their heart to think that it's too full will actually result in resolution of the bradycardia. So you want to monitor them. You want to put them on telemetry. You want to give them blood pressure management. Now, this is not the time for the labetalol pathway. Their heart rate is slow, and labetalol has a beta blocker. And part of labetalol's ability to manage or to lower blood pressure has to do in its beta blockade effect. So we don't want to use that pathway, but the hydralazine pathway or the procardia pathway would be perfectly acceptable. You want to get rid of that extra volume. Her BNP was 412. That means that she has extra volume in that right ventricle that we need to take care of. Now, if it persists, we need to consider, does she have hypothyroidism? Keep in mind in pregnancy that thyroiditis postpartum is really common. Did she get some type of infection like a myocarditis? Especially in the seasons of flu and COVID, those have to be in the back of our minds. What about, is she taking some medication? In those patients with persistent symptomatic bradycardia, temporary pacing may be necessary. But for most pregnant women, bradycardia can be a presenting sign of postpartum preeclampsia and should be considered such until proven otherwise. Let's look at another case. So this is a 32-year-old at 34 weeks who presents with chest pain and shortness of breath. She says she has been seen by the cardiologist in the past for an abnormal heart rate, but she has not been seen since she was pregnant. Her labs are unremarkable. In your history, you also find out that she's been in Florida and she had a beach vacation for her baby moon. She states that she thinks she was trying to stay hydrated, but she also wanted to make sure that she got a really great tan. Supraventricular tachycardia is one of the most common pathologic arrhythmias in pregnancy. It is often seen in patients with a previous history, can be seen in patients who present with hyperthyroidism in pregnancy, and frequently associated with dehydration or overheating during pregnancy. It is defined as a heart rate greater than 120. About 60% of the time, there's aventricular nodal reentrant tachycardia, and about 30% of the time, there's AV recantrant tachycardia. This may be increased in pregnancy, especially in the third trimester. And although we say the definition of tachycardia or tachyarrhythmias is greater than 120, most people who present with supraventricular tachycardia are usually in the 160 to 180 to 200 range. Now, the first thing is that you can do just simple measures. Carotid massage. Have the patient bear down, cough, and rub her carotid. That's a Valsalva maneuver. The next is, if it does not go away, IV adenosine. Now, I've had people get all nervous because they're worried about the baby and whether or not the baby's heart rate will stop if we stop the mother's. The answer is no. You can give 6 to 12 milligrams. Your maximum dose is 18 to 24. It has a short half-life and no fetal effect. And keep in mind that pregnant women often have a larger volume of distribution and may require just a little bit more medication. And while it may be unnerving to watch the mother's heart stop for a second to reset, it is one of those things that can actually help treat supraventricular tachycardia. If that doesn't work, then the patient may need electrocardioversion, especially if she's hemodynamically unstable. You can also use other medications such as diltiazem in order to maintain the patient, or metoprolol once the patient is taken out of her rhythm. In patients with WPW, beta blockers are the choice for taking care of those particular patients if they're supraventricular tachycardia due to this phenomenon. But as I said, calcium channel blockers such as diltiazem, verapamil are all acceptable in pregnancy, along with beta blockers such as metoprolol to treat this condition. The one thing I want to say before we leave supraventricular tachycardia is treatment is paramount, especially if the patient is hemodynamically unstable. One of my patients told me that they sat around and people were worried about cardioverting. It's not going to hurt the baby. Anytime you have hemodynamic instability, you're not going to perfuse your uterus well. So it is of paramount importance to tackle these patients quickly and to treat them aggressively as you would for anyone else who presents with this condition. Now we're going to talk a few minutes about atrial fibrillation and atrial flutter. Remember, I was telling you that the pregnant heart is susceptible to arrhythmias. You may see some atrial arrhythmias that are transient. Again, they're less common in pregnancy, but one of the things one must think about when you have someone in atrial flutter or an atrial arrhythmia is thyrotoxicosis. This is particularly important if the patient presents with hyperemesis or if the patient has gestational trophoblastic disease. And while often people think about the fact that gestational trophoblastic disease can present after pregnancy, it can also present concomitantly with a pregnancy. And we had a patient in our institution who had gestational trophoblastic disease and a viable fetus. So don't rule it out if that's something that you're concerned about. Other underlying causes are congenital heart disease, metabolic issues, hypokalemia and hypomagnesemia, and then long-standing hypertension, because once the ventricle begins to become thickened, then you can get atrial arrhythmias as well. Beta blockers work for this particular condition along with calcium channel blockers. These medications are not contraindicated in pregnancy. You can consider cardioversion for patients who are unstable or who are escalating, have medication needs. Amiodarone is something that we would not use during the pregnancy because it can concentrate in the fetal thyroid. All of these patients who have arrhythmias, are especially those patients who stay in atrial flutter and fibrillation, will need to be on anticoagulation. Remember that pregnancy is hypercoagulable state, so patients are even more likely to throw an embolus or a blood clot during this time. Let's go to our third case. This is a 32-year-old gravida 2, para 1, who's at 7 weeks gestation. She complains of nausea and vomiting. She has a history of seizures. On further questioning, the patient had a defibrillator placed after taking some medications. On exam, your patient is curled up in bed, her vital signs are stable, but she reports a seizure after being placed on telemetry. When you look at her EKG, her QT interval is prolonged. I present that case as kind of a patient who presented this way. The seizure was actually her defibrillator firing to put her back in a normal rhythm. Prolonged QT affects about 1 in every 7,000 women. Females are greater than males. The QT for males is 440 seconds. For females, it is 450 seconds. And for pregnancy, is slightly longer. Patient may present with history of syncope. She can have chest pain. She may actually have a family history of sudden death because prolonged QT can often be genetic. They're more likely to have torsades de pointe, and they can have seizures due to decreased blood flow to the brain during the episode, or in our case presentation, due to their defibrillator being fired. There are 6 types of inherited prolonged QT. Type 1 is about 99% of patients. There is a Romano-Ward syndrome that is autosomal dominant. In addition to that, you may want to know that Jarrell, Long, and Nielsen syndrome causes prolonged QT and is associated with congenital deafness. That is autosomal recessive. This is very important in pregnant patients because not only do you need to worry about their particular etiology of their prolonged QT syndrome, but you also need to be able to counsel them regarding the issues that may be associated with their offspring. For the most part, prolonged QT can be acquired. Potassium is low. Magnesium can be low. And then the medications that we so love: amiodarone, azithromycin, and some of our SSRIs, such as citalopram and escitalopram. Those are the two SSRIs that can cause prolonged QT. Beta blockade is associated with a decreased incidence of cardiac events through pregnancy and can be used. In this particular case, propranolol is your preferred agent. There is an increased risk of events in the postpartum period. In a study of 422 women, the risk of syncope or aborted cardiac arrest or sudden death 40 weeks pre-pregnancy was 3.8%, postpartum 24.4%. And I think that we want to pause here to remind people that postpartum, there are still significant blood shifts, autotransfusions, and issues that increase the risk of cardiac arrhythmias. Let's go to our fourth case. So this is a 30-year-old gravida 2 para 0. She is in labor at 41 weeks. She complains of chest pain and shortness of breath, and she states that she has had issues and was informed that she needed an ablation. And her first pregnancy was terminated, and she was told it was not safe to become pregnant. Her electrolytes and labs are normal. And when you're looking at her EKG, what you're going to see is that it looks like that she has ventricular tachycardia. But she's talking to you. You're like, what do I do now? This is a variant of ventricular tachycardia called left ventricular outflow tachycardia. Most ventricular tachycardia is idiopathic. It arises in the right ventricle below the pulmonary artery. It rarely accelerates to an unstable rhythm, but when it does, it is life-threatening. Most of these arise in the right ventricle, and the patient may experience runs of non-sustained ventricular tachycardia. These usually respond well to beta blockade. However, there are certain types of things that we need to be aware of for ventricular tachycardia, as this is a life-threatening rhythm. Monopolymorphic ventricular tachycardia is often associated with structural heart disease, long-standing hypertension, decreased myocardial perfusion, and subendocardial ischemia. Now, let's think about this. Who is at risk? Hypotension, decreased myocardial perfusion, subendocardial ischemia. 42-year-old with postpartum hemorrhage is someone who may go into ventricular tachycardia when she's having her bleeding episode. It can degenerate into ventricular fibrillation, which we know is life-threatening, and it causes a significant risk of cardiac death. In one particular case that I reviewed, the patient had an issue. She went to the operating room. She became hypotensive. She had ventricular tachycardia. She then had ventricular fibrillation, and they could not recover. So paying attention to ventricular tachycardia is extremely important, and it's especially important in our patients who are advanced maternal age. This is an emergency. IV lidocaine, DC cardioversion, and amiodarone. Again, in an emergency, amiodarone is fine. It's not to be used long-term to maintain rate, but in an emergency, it is fine. Long-term, if the patient is still pregnant, it will concentrate in the fetal thyroid and cause fetal thyroid issues. But at this point, we're not worried about fetal thyroid issues. What we're really worried about is keeping the patient from coding. Now, that's polymorphic ventricular tachycardia, which usually, terminates itself in a few seconds. Again, it's associated with electrolyte disturbances, most likely potassium and magnesium. It can be also seen in macrolide antibiotics. There goes the pesky azithromycin again, which is also associated with prolonged QT. Drugs that block the potassium channel, and interestingly can be associated with non-sedating antihistamines such as Zyrtec and Claritin, which we often prescribe patients. Normally, this is self-limiting and only lasts a few seconds. In looking at this particular case, what I do want to point out in the left ventricular outflow tachycardia, she was treated with beta blockade. Beta blockade slowed down her heart rate. We went on to have a successful delivery. But it's important to know the differences between ventricular tachycardia and to make sure that you examine your patient appropriately. What about the management of the fetus? In an unstable rhythm, treat your mother. I'm going to say that again. In an unstable situation, treat your mother. If you stabilize your mother, you will stabilize your fetus. Be prepared for the management during cardiac arrest. And we know what that is: the ability to perform a cesarean section within 4 minutes post-arrest. So if the mother is unstable and you think you're going to have a code situation, you need to have all hands on deck. But the first thing is to treat the mother. In stable rhythms, you can do continuous fetal monitoring. And I like fetal monitoring because fetal monitoring tells us more than about the fetus. It tells us about our perfusion. Because see, while we may think the baby is the most important thing, nature thinks that the baby can and might need not to get perfused. So one of the things that happens when a mother is sick, she begins to shunt blood from the splanchnic bed, which is her uterine arteries. The sicker the mother gets, the more she's likely to shunt this blood. And you're more likely to see that in an unstable fetal heart rate tracing. So your fetal heart rate tracing can act like, for all intensive purposes, a PA catheter, pulmonary artery catheter, in some ways to tell you about how well you're resuscitating your mother. Because if you resuscitate your mother well, your uterus will perfuse well. Now, let's talk about medications. Most medications for delivery are Class C. And we use Class C medications all the time. I have pointed out to you the one medication that is Class D, which is amiodarone, which we like to try to avoid. Otherwise, most medications can be used and should be used if we need to stabilize our mother, and then switch to a more baby-friendly medication if it is indicated. Now, there's some other treatments. Implantable cardiac defibrillators have no effect on your baby. They can be placed in pregnancy after 8 weeks and should be considered in patients who have a potential life-threatening arrhythmia. In fact, my cardiologists at my institution know that if I have a patient with a recurrent life-threatening arrhythmia, I'm going to be talking to them about placing a defibrillator, because arrhythmias in pregnancy are just unpredictable. And what we don't want is the patient to have sudden death. Well, what about cardiac ablation? For patients with drug-refractory arrhythmias, cardiac ablation is not contraindicated. You can use electroanatomical mapping systems. There are ways we can minimize radiation exposure. And some of these cases can even be performed without fluoroscopy. What we need to be thinking about more is treating our patient as if she is not pregnant, but taking the precautions to protect the fetus when needed. What about deliveries? You need to know where patients should deliver. In Tennessee and throughout delivering hospitals, there are different levels of care. Level 1, level 2, level 3, and level 4. Patients with low arrhythmias can deliver at level 1 or 2 hospitals as long as they're comfortable with the patient. Medium risk deliveries should probably deliver at a level 3 hospital and with someone who feels comfortable taking care of the pregnant patient. And then high risk arrhythmias need to be planned for and delivered in a level 4 center where you have a cardiologist, an EP specialist, and the ability to respond to the arrhythmia at hand. Well, what about peripartum cardiomyopathy? Everybody wants to know a little bit about that and its association with arrhythmias. It's defined as heart failure less than 45% occurring toward the end of the pregnancy in the absence of any other identifiable etiology. Remember at the beginning when I was talking about bradycardia and postpartum preeclampsia and a blood pressure of 180/100? Well, your ejection fraction may be around 45% when you do an echo in someone with a blood pressure of 190/100 or 180/110. That may resolve once their blood pressure is treated and the preeclampsia resolves. So before we call someone a cardiomyopathy or peripartum cardiomyopathy, we need to make sure that we have no other etiology. But the management is the same. Afterload reduction, ionotropic support when needed, anticoagulation. You want to, when these patients present, have the 40-40-40 rule. Head of the bed at 40 degrees elevation, 40% oxygen, and 40 milligrams of Lasix IV. And we need to keep in mind that some patients need extra protection during the pregnancy and should they go home? This is especially true with people with life-threatening arrhythmias who don't have an implantable defibrillator or patients with significant heart failure. So a portable or external defibrillator may be appropriate. I've seen a case in which the patient did well during her pregnancy but had a history of arrhythmia prior to pregnancy, and at 7 days postpartum came in with an arrhythmia and she could not be recovered. But she was not sent home, or there had not been a discussion of any type of protection for her in the postpartum period regarding arrhythmias. Keep in mind that it takes 6 months for the cardiovascular system to go back to normal. And while there may be controversy about when or when not to use external defibrillator device, it should be something that is discussed with the patient, and there should be shared decision making regarding the risk and benefits. Now, I just want to touch on was bromocriptine. Some small studies that have shown bromocriptine in patients who have arrhythmias who also then have compromised left ventricular ejection fraction may be treated with bromocriptine. Keep in mind that bromocriptine also cannot be used if the patient is breastfeeding. So again, this is a time for shared decision making with the patient, the cardiologist, the maternal fetal medicine specialist, and other members of the multidisciplinary team. Well, what is the prognosis for peripartum cardiomyopathy, since so many people worry about this in terms of arrhythmia? The predictive risk factors are if the patient's left ventricle is less than 25 to 30, if they have some findings on echo, such as left ventricular shortening and in diastolic dimension that's elevated, if their BNP stays persistently elevated, and whether or not they have hypertension and preeclampsia at the time of diagnosis. I just pointed that out. Those are the types of things that can tell us whether these patients are going to recover or whether they may need a lifelong implantable defibrillator or even possibly a cardiac transplant. So in conclusion, arrhythmias are more common in pregnancy. Most arrhythmias are self-limiting and don't require treatment. And I will tell you a story. We had an arrhythmia here in the in recovery room. And everybody was all, excited. She was an atrial flutter, and she had just had a cesarean section, and she was 40. And they were like, well, what are we going to do? And should we start medications? And so I just kind of was busy. So I kind of slow walked it. A cardiac fellow came by, other people came by. And in my mind, I'm like, the auto transfusion of pregnancy is about 4 hours. And sure enough, at 4 hours, she converted, and she never required medications and never did anything else. Management of most cardiac arrhythmias is similar or very close or about the same as it would be in the non-pregnant patient. So what we must do is make sure that we treat these patients as if they were not pregnant, with considerations for the fetus when indicated. And then we need to be thinking about planning for these patients who have recurrent or life-threatening arrhythmias, or have an arrhythmia for which a center may be uncomfortable taking care of or do not have the expertise. Those patients may need to deliver in a center with a higher level of care. I hope that during this time that you feel now more comfortable taking care of arrhythmias, less scared when that patient who presents to your emergency department in supraventricular tachycardia, that you know that you can go ahead and treat them as you would if they were not pregnant, and consult your obstetrical colleagues, and also understand that while cardiac arrhythmias in pregnancy may be more common, most of them are self-limiting, can be treated easily, and in paying attention to them, we can decrease maternal morbidity and mortality and provide optimal outcomes, not just for our babies, but for our mothers as well. Thank you so much for your attention.